Kellner. I'm a cerebrovascular neurosurgeon here at Mount Sinai, and today I'm going to be speaking to you about remote patient monitoring for COVID tracking at home. This presentation is going to be half given by me for this portion, the initial portion, and then half by David Putrino, who is the co-founder, co-director of the Precision Recovery Program, which is a broad remote patient monitoring program that we originally developed for managing patients with stroke at home. And when COVID hit, we tried to quickly adapt that to the COVID environment and found that to be a very effective way to monitor patients at home. So we're both going to share that experience with you. So this is a curve that everyone became very familiar with in March, when we were very afraid that we were going to exceed the capacity of our healthcare system if too many people got infected with COVID and if our health system didn't respond quickly enough. And so this graph I remade, but I remade it from a graph I saw in numerous articles, epidemiological articles talking about healthcare system capacity. And so basically, this is looking at the number of daily cases, the new cases per day that are coming into a healthcare system. So that's not one hospital, but it's the entire system, assuming that the system can move resources around within the system to meet capacity. Without protective measures, the healthcare capacity is exceeded in this graph. You can see that the dotted line is healthcare capacity. And so there will be some period of time where patients are being admitted or need to be admitted or need to be treated, and there's not enough resources for them. So with protective measures, we all heard that we could flatten the curve, and we did that. This is a picture I grabbed from online of Times Square in late March. During this period of time, I was riding my bike to Mount Sinai West, and I would divert to Times Square every morning just to see this. So with flattening the curve, what if in a hypothetical healthcare system, flattening the curve does not get you there? In this graph here, you can see that we have flattened the curve in this graph, but yet the healthcare system capacity is still exceeded. So what else can we do? We can increase the healthcare system capacity, and we did that. This is Central Park. Many of you remember this image daily during March and April. And every one of our hospitals in the Mount Sinai Health System had an adjunctive ER tent that was set up for triaging and for overflow. So in this model now, we have met capacity, because you can't increase healthcare system capacity immediately, but you can over time, as you get PPE from other places and as you get more ventilators from other places, you can increase your capacity over time. And so this kind of models a general increase over time of healthcare system capacity. And in this model, with protective measures, with healthcare system capacity increase, we have met the need. But what if, even with those two things, we did not meet the need? What can we do to increase healthcare system capacity immediately? And this is where this project comes in. This is about increasing healthcare system efficiency. The way that we thought to do this would be to increase the data that we have coming from patients in the community and work to better triage them into the hospital or keep them at home. And so in this graph here, in this figure, patients who are critically ill are red, and those patients need to be admitted to the hospital. Patients who are unstable are pink, and they need to be admitted to the hospital. And patients who are stable and can be watched in the community are green. And so many green patients in this pandemic were coming into the ER, and we're either getting admitted for a short period of time or we're getting triaged back home after coming into the emergency room. But when the numbers are high, those patients, if they can be treated at home and monitored at home, that's much more efficient and would save resources in the emergency room and would also limit transmission of the disease if they were positive. So we thought that by learning about the patients while they're at home, we can acquire the data to manage them at home and to trigger escalation when necessary to get them into the hospital. And by performing this intelligent triage, we would be able to increase the healthcare system efficiency. To do this, we employed remote patient monitoring. This is a technology that enables monitoring of patients outside of conventional clinical settings, such as in the home or in a remote area, which may increase access to care and decrease healthcare delivery costs. This is a definition that we put together and paraphrased from CMS, which CMS decides what services are going to be billed and be deliverable by a physician or a medical or a healthcare system. Remote patient monitoring became a billable service in January of 2019. And that is when David Putrino and I started this program and started caring for patients using this care philosophy, this care paradigm. Precision Recovery, the program that we started to deploy remote patient monitoring, is a platform that we designed using the software I'm going to show you. And this does enable remote patient monitoring outside the hospital. And remote patient monitoring includes a few different features. It must include physiologic monitoring of some form. And currently there is a loose definition surrounding what physiologic monitoring is. And it can also include patient-reported outcomes. So patients can answer questions, fill out surveys, and they can also take their blood pressure, input their blood pressure into the app for us to see it in an asynchronous way. So not live, but to see it at some point. Or remote patient monitoring can have a physiologic monitor that's directly connected to your app. So you connect your Omron blood pressure cuff. The Omron blood pressure cuff automatically uploads your data to the database, and then the clinician team can see that data later. The program that we designed was based on some information we had about remote patient monitoring that was performed in congestive heart failure. The cardiac literature had investigated using remote patient monitoring, and a randomized clinical trial had actually been performed. And that clinical trial showed that measuring patients' weight at home and their blood pressure, keeping tabs on them, did not seem to improve outcomes for their primary outcome measure in that large randomized clinical trial looking at CHF. However, the review of that trial suggested that the patients were not adhering to the protocol. They had the app, but they were given the app and they were told to just do it, just get it, just log your data, and logging the data, allowing you to see the data, and having physicians monitor that data will improve your outcome or facilitate improving your outcome. But what happened is a large percentage of people were not adhering to the protocol. And so with that in mind, and with David Putrino's experience with remote patient monitoring that he'll discuss, we came up with this cyborg protocol, which is a half algorithm, half human protocol. And for now, we really feel strongly that this is the right way to go with remote patient monitoring until the algorithm part becomes so good that it seems human. So what we did is the protocol is that patients will enter data daily, and then that data will be reviewed with them with a human being on a video call, on a Zoom call just like this, weekly. And that 10-minute video visit is actually pretty essential, we found, to having patients adhere to the protocol. And they also found that to be, specifically with COVID, a critical time point where they would accumulate questions and then they would ask them all at that brief weekly video visit. The applications we used to deploy this remote patient monitoring were this app called MyCap. This is a freely available app that's generally used for clinical research, but can also be used for clinical services. And it is a mobile patient-facing version of REDCap. If any of you have done any clinical research, you probably are aware of REDCap, which is a very common research database that is used for multi-institutional clinical research. And in our institution, even single institution research, all of our research projects in the cerebrovascular group are in REDCap. And it's a great database tool. What this MyCap version allows you to do is a patient will activate the MyCap on their device, and every time they put data in, it automatically goes into the REDCap database accessible to the clinicians and researchers. When the pandemic started, some forms of video conferencing were not allowed with patients. But at the beginning of the pandemic, as you all recall, there was a public health emergency declared, and CMS and released a statement and a policy that additional web video conferencing software would be permitted during the pandemic to permit increased remote care for patients. And so Zoom is a app that Mount Sinai actually has a HIPAA agreement with, and we're able to do patient encounters through Zoom. And so that's what we were using during the pandemic, mostly because it's one app that patients became quickly familiar with, and most of them were able to use that. It also permits us to record the encounters in a very easy way. So then we get to the physiologic monitoring, and for patients who were high risk, we were able to get them an oximeter. At the time, oximeters were not easy to come by. They quickly sold out on Amazon, and so we had to do quite a bit of work to find warehouses and medical distributors in the Northeast that had pulse oximeters. And so we were able to get our hands on a few hundred pulse oximeters, and we gave those to, we had to ration those, not severely ration, but we could only give them to about 50% of the patients who were enrolled. So we gave them to patients who were high risk. And initially we categorized that as 55 and above, based on age being the single largest factor for determining if a patient was going to have severe COVID. And then when we realized we had enough pulse oximeters, we were able to lower that age to 45. And so later in the pandemic, patients enrolled in this program over the age of 45 are getting a pulse oximeter. Then patients who had any cardiac history, we did our best to get them a blood pressure cuff so that we had 2 physiologic monitors. A lot of patients also, by the way, also already had a pulse oximeter or a blood pressure cuff, and every single patient already had a thermometer. So we did not provide thermometers, but we did have thermometer data to work with in pretty much every patient. Here's what the app looks like from the MyCap standpoint. When you turn on MyCap, you're able to brand it and really write whatever you want on the welcome page. And it was very simple. We designed this so that we would be able to capture data from as many patients as possible, despite some of them probably not having, not being as technologically advanced as this group now. So we had patients filling out initially their demographic information, and then they had a daily COVID survey that they would fill out. And if patients seemed like they were high risk, either from age, having a comorbidity that put them at high risk for decompensation with COVID, or having some issues. If a patient met any of those criteria, then they were asked to fill out the data more than once a day, maybe twice a day. Maybe they were checked in on more than that. Here's what our daily survey looked like. It was very simple. A colleague of David Putrino, who is a respiratory expert, provided the questions, and we were basically asking about every symptom associated with COVID. For example, are you coughing? Do you have chest pain? And we would also ask Likert scale information for every question. How bad is your shortness of breath? How bad is your chest pain on a scale of 1 to 4? Do you feel like you're breathing faster than normal? Have you noticed a bluish tinge on your lips? Are you finding it difficult to concentrate? So these are questions getting at, are you having symptoms related to hypoxia? And we were using hypoxia as one of the main criteria for advising a patient to come into the emergency room. If a patient seemed like they were having hypoxia and they had not previously had a pulse oximeter, we would try to get them a pulse oximeter. Here is the protocol kind of visualized. And so just to repeat what we're doing, and this is what we were doing in stroke patients originally for about a year, and then started doing in COVID patients. And this consists of a daily check-in where you're getting a physiologic value from that patient. They're answering a few questions. So in this case, it was about 12 questions for COVID. We were getting their pulse oximetry if they had it, blood pressure if they had it, temperature if they had it. And then you can see that there was a weekly video visit, that's the blue line. And then we had a much more intense 30-day visit where we were asking a lot more questions and spending a lot more time with the patient. In the future, we hope to further develop this 30-minute monthly visit and really make this a disease-specific self-management education visit where there's online curricular material available. During COVID, some colleagues quickly developed a pulmonary physical therapy video that taught patients how to do the right breathing exercises to increase their lung capacity if they had any COVID-related symptoms. So a lot of patients found that to be really helpful for helping them breathe, number one, but really helping them with their anxiety also, knowing that they were doing something that seemed to be helping. It certainly helped patients calm down, and it really gave us a lot of positive feedback related to this program. As you know, some patients had COVID and it was easy and they got over it in a few days, but some people had prolonged inflammatory responses and prolonged symptoms that lasted up to a month. And in some cases, David will show you, some had what's called long hauler symptoms. And maybe you've seen the New York Times articles about this, where the symptoms can last many months and they change in character and they become much more chronic lethargy and concentration problems and subtle cognitive problems and pain in multiple places. So it can be a very challenging syndrome. So that 30-day video visit is, I think, going to be an important part of remote patient monitoring going forward. I wanted to show you, kind of get a sense of how big this program became. At the beginning, we were just putting this together and telling people about it word of mouth, but it increasingly became more official throughout the experience. And you can see in early May, we actually began to exceed the number of patients cared for in the Precision Recovery Program with COVID was more than the number of patients admitted in the Mount Sinai hospital system, kind of around the number 600, which occurred in early May. And at the peak of our enrollment, which was actually beyond the peak of the Mount Sinai enrollment, as you can see here, the red line is still climbing in this graph, we were caring for 800 patients actively with COVID, monitoring them at home. Sorry, I need to pause again. Yeah. And so a few hospitals systems quickly adapted a system similar to what we did. And so I just wanted to give you two examples of that. And some publications have come out and our publication is also pending. So this is a remote patient monitoring that was started at UPenn. And they were using a system that we have adapted towards that's text-based. And this uses a text bot where the patient will be texted questions, they respond, those answers are put in the database. And then if it seems like they're giving answers that require escalation, then they're either advised to call 911 immediately, or they're advised to, or if a physician member of the team is advised to contact the patient. And so we, in our program, we're trying to do our best to manage the patients within the confines of the program. Of course, if they met certain criteria, we had them call 911, but we did not want to reflexively have patients call 911 or reflexively come in. We were trying to do our best to intelligently triage them. And so we had an available team of mid-level providers, which consisted of physical therapists, occupational therapists, nurse practitioners, physician's assistants. It was quite a big team at one point. And that escalation initially meant that a patient who had worsening symptoms, that provider caring for that patient would then contact that patient with a video visit that day and discuss the patient's symptoms with them and work with them to decide if they really needed to come in or if they could try something else or if they could continue monitoring at home without any change in their care. If that mid-level provider felt like they needed additional help making that decision, then they would add on an MD to that call. And we had a number of MDs who were available throughout the pandemic and able to jump on. And so I thought that was a really interesting and effective system to bring real clinical evaluation into the remote patient monitoring plan And that's why I say that it's half algorithm and half cyborg. There were some automated responses from us, and there were also some actual human contact to make the decision whether to escalate care to number one, a mid-level provider, number two, an MD, and number three, into the hospital. And so at this point, I'm going to hand it off to David Putrino, and I'll take any questions live. Thanks very much.
Okay, well, thanks, Chris, for that overview of our acute COVID care platform. I also want to discuss the pathway, the way that we got patients into the program, because that's something that is really important in creating a telehealth product that is easily accessible and easily usable by clinicians. We need to make sure that there are clear pathways and ways of getting into the program. So one of the most common ways of involving people into our acute COVID care pathway was to manage patients through urgent care or the emergency department. So the way that this would go is that a patient is at home, they're starting to feel symptoms that may be aligned with COVID-19. They would consult Mount Sinai's urgent care platform, which is Mount Sinai Now, or they would actually, take themselves to the emergency room physically. At that point, there's a decision. The patient is either admitted or not admitted. As we know, when surge was happening, it was very unclear who would be admitted and who would not be admitted, because we didn't have a lot of beds, so only the sickest cases were being admitted. At that point, when they were discharged, our emergency medicine doctors and our urgent care providers found it very comforting to be able to make a direct referral to Precision Recovery, because it allowed them to make sure that the person continued to be seen and continued to be checked in on a daily basis without them having to loop right back to urgent care and go through all of that procedure again. So it was a very nice, clean way of making sure that even individuals who were not admitted into the hospital managed to get a high standard of care after they were told that they weren't going to be admitted into the hospital. The second pathway is, of course, that the patient's admitted. So they arrive at the hospital. There are some concerning things going on in their physiology, and the doctor at the emergency department says, you know what, we're gonna bring you into the hospital for a couple of days because we're concerned about how you're doing. At that point, they receive great care within the Mount Sinai health system. At the point of discharge, once again, we found a pathway where most of the internists found it really comforting to know that as soon as they discharged the patient, someone from Precision Recovery would be checking in on the patient on a daily basis. So again, we would receive a referral to Precision Recovery. These referrals happened either through Epic or through some of the other inter-hospital messaging services that the Mount Sinai health system uses. But it was a really clean and seamless way of integrating patients who are being discharged, who physicians thought needed just a little bit more than the typical post-discharge care to make sure that they remain safe and healthy post-discharge. So those were the two hospital-embedded ways of enrolling people into the Precision Recovery program from Mount Sinai. The other need that we saw emerge during the surge was that there were a number of people who were just generally frightened about symptoms that were emerging. They recognized that they were not severe enough to reach out to urgent care or the emergency room for consultation, but they still wanted monitoring. And for that particular pathway, we set up a hotline that we monitored on a daily basis, and we had a number of coordinators just tracking the hotline, making sure that people who were contacting, if they were contacting and they were in crisis, we made sure that we referred them to urgent care or the emergency department. If they were contacting and they fit the inclusion criteria, which is, not in crisis, not struggling, but concerned about emerging symptoms, what we would then do is schedule them an appointment with a physician. And from there, the physician would onboard them into the precision recovery program and refer them to one of the precision recovery providers that would then perform day-to-day monitoring. So these were the ways that we brought people into the acute COVID care pathway. Now, it's worth mentioning that as COVID has persisted and as we have started to need a number of different mechanisms to make sure that people continue to get great care post-COVID and in post-COVID times, meaning they can't come as easily and as readily to a hospital environment as they used to. We also found the need to develop a chronic care pathway. Now, in terms of chronic COVID care, we've started to notice that there are around 3 different buckets of patient symptoms that need managing. And so we've created precision recovery environments for all of these different programs. I'm not going to go into too much detail about all of these different chronic care pathways because I think we're going to have some really great speakers like Neha and Amy and many others who will be discussing some of these in much more granular detail. But it's just worth mentioning that from both an innovation perspective, which is one of the things that we always notice is when you hurry to meet a need that people are having in innovation, what often happens is as soon as you meet that need, you realize that no one else has met that need before. So all of a sudden there are 4 or 5 avenues that you can suddenly go down because you've entered into new territory. And immediately what happens when you enter into new territory is the users of your service start to say, hey, this is great. Can you do this? Can you do that? Can you do the other? So so as we moved from seeing primarily acute cases, over 1,000 acute cases, to starting to notice that there were, according to the CDC, 30 to 35% of acute cases were starting to lead into longer term cases. We felt the need to start to build out specific modules for each of these cases. So, we created these 4 different buckets, and really there's the overwhelming, 65 to 70% is the happiest bucket, right? The patient's fully recovered, they had acute COVID, it was terrible, they got through it, and now no further intervention is required. That's great. We hope that all of that happens, but that happens in all cases, but unfortunately it doesn't. So we then have this second bucket, which is rather predictable. It's a known condition. And these are individuals that got quite sick. These are individuals who ended up on a ventilator, or they ended up in the ICU, and they've made a full recovery, they've been discharged, but they're now experiencing symptoms that are consistent with what we call PICS, post-ICU syndrome. And so this is a very complex syndrome. It involves lots of different elements that range from, trauma and psychological related issues that need to be addressed, to physiology issues, heart and lungs not performing the way that we want, deconditioning issues, so not necessarily issues to relate to organ damage, but issues related to just the fact that you've been laying in a bed for a few weeks and not getting up and moving around. And then other issues related to cognitive rehab that need to happen, and so on and so forth. So it is it's a complex syndrome. It's a comprehensive syndrome that requires a multidisciplinary disciplinary care program. And so we created a precision recovery program with collaboration from both PICS patients and doctors that are really well really experienced in treating PICS. And we created a precision recovery PICS program to enroll patients into. The second cluster of patients that we really had to address were patients who were simply deconditioned because they had experienced a severe case of COVID. Maybe they weren't even hospitalized, but their lungs have sustained some damage. And what we need to do now is put them through a pulmonary rehabilitation program that allows us to assist them in having sort of a good level of recovery of pulmonary function following COVID. And so we created a pulmonary rehabilitation version of precision recovery to assist in addressing those issues. And we've been working with pulmonary therapists and other rehabilitation specialists to make sure that these people get the care that they need. The final issue that we have been seeing is something that Dr. Amy Kontorovich will touch on, which is many patients were experiencing symptoms that were consistent with something that is often called post-viral dysautonomia. We haven't put a name onto this syndrome in our COVID patients just yet, except to say that it is a post-acute COVID syndrome. So the symptoms that they're experiencing are no longer acute COVID symptoms. The symptoms appear related to COVID. But beyond that, we don't want to really speculate on exactly what this syndrome is until we have more data. But what we can say is that roughly 10 to 15% of our patients are experiencing it, and not necessarily patients who had the most severe symptoms either. So it is something that we're really closely watching and monitoring, especially since many people in the community who have assumed the risk of COVID. These are the people who are younger and healthy, who are saying, hey, it's not so bad if I get COVID because I'm young, I'm fit, I'm healthy. COVID only adversely affects older adults or people with underlying healthcare conditions. What we're really trying to get out in terms of awareness about this particular last group of patients is that that is not necessarily the case. Many of our patients are under 40, previously fit and healthy, and only had a very mild case of COVID. So when you ask them about their COVID symptoms, they're like, oh, it wasn't too bad. It was only 2 weeks after my symptoms disappeared acutely that I started to get this new set of symptoms that was really bad. So this is something that we're actively looking into. And like I said, Dr. Kontorovich will talk about this in a lot of detail. So I'll leave it there. In addition to COVID-related work with precision recovery, it's also worth mentioning that we've been reaching out to many of our collaborators through the Mount Sinai Health System to assist them in setting up their own versions of remote patient monitoring. So once again, this idea of creating an innovation that adds value to a workflow is quickly picked up in lots of different sectors. And so this has been a process of a lot of creativity and a lot of and a lot of experimentation with all of these different doctors from all of these different walks of life, as we start to try to create remote patient monitoring programs for all of these different these different specialties and subspecialties and diseases that require daily check-ins. But up until now, physicians have been content with the model of, come in semi-regularly to the hospital for your regular check-in. Now, with the pandemic and the crisis, we're seeing that there is an opportunity to embed these technologies in a way that doctors get more up-to-date, more detailed, and more continuous data, and sometimes even more objective data to make clinical decisions about. And so for my final 3 or 4 minutes, I just wanted to share with you guys some of the technologies we've been developing to support these great physicians as we develop remote patient monitoring solutions for them. So, for instance, many of the conditions that you're seeing here are related to neurological conditions. So one of the first things that was requested of us was to create a eye tracking system that could work off of webcam or phonecam data. And so working with some really great computer vision and machine learning gurus, this is Elliot, one of our wonderful computer vision programmers. We've started to create eye tracking protocols that allow us to simply eye track from a webcam. And once we got this initial data pipeline set up, one of the things that we started doing was starting to create challenging real world environments. So here, as you can see, I'm in my house. I'm backlit horribly because this is when we're collecting data from patients. This is a concern. Sometimes patients will not create optimal circumstances to analyze the data that you're creating. So what you need to do is test things out in challenging environments, really put the technology to the test to make sure that if there are specific parameters you need for the data capture procedure, you can get them. But if there are not, you can say to the patient, look, sit in your living room. Don't worry that there's a cat in the background. Just, get it done. Get what you need to get done, and we'll take care of the rest. And from this technology, what we get is just a readout like this. What this allows us to do is just look at horizontal axis motion, vertical axis motion, and then from there we can run people through different tests. So, hey, can you move your eyes in smooth pursuit in a circle? Can you move your eyes from left to right, up and down? And we can see how smoothly they can perform that task. In addition, one of the great things about using this particular machine learning algorithm is that our frame rate is only limited by the camera. So if we've got a camera that captures data at 200 hertz, our output will be 200 hertz because it does frame by frame analysis. So that has been a really great way of controlling the quality of the data that we get based on the needs of the clinical team. Finally, a little bit more fun is we've been doing a lot of full body motion capture, again, in like very real world environments. As you can see here, we're not just capturing facial features, we're capturing full body and hands. This has been really invaluable for our stroke researchers and our stroke physicians who are studying motor recovery of the upper limb after a stroke. We've also been moving in a more granular direction with these motion capture capabilities in things like Parkinson's disease, so we can measure tremor and things of that nature. So this has really opened up a large sort of area of remote patient monitoring capabilities that we hope will result in enhanced patient care. The final thing I want to share with you is, something that's a little bit for the future, but some of the work that we've also started to engage in is advanced telerehabilitation. So what you're hearing here is one of our providers working with a neurological patient who is playing video games that are completely controlled by her motion. And what we get on the back end is the ability to analyze these data, have very granular data related to not just compliance and adherence to a home exercise program, but actual kinematics. How much more is this patient moving this week than she was last week? Which has been a real issue with tracking progress in neurological patients. So we're really excited about the future of technologies such as these, because they can really allow us not just to provide a better standard of care, but to collect data that allows us to make discoveries about the best forms of care for each subset of patients. So I'm gonna finish it up there, but I hope that this has given you a bit of an appetite and a bit of an understanding of all of the needs that we're having, as well as, you know, what's possible when you apply great computer science to these clinical problems.